everyone. My name is Ray Massey, and I'm the Patient Engagement Program Manager for AST's Power to Save. It is my pleasure to introduce you to our presenters. This is Claire Kamel and Bill Applegate, two of AST's Directors of Government Relations in Washington, D.C. They represent the Society before public policymakers on Capitol Hill and federal agencies. Claire, Bill, and their team are the eyes, ears, and boots on the ground in our nation's capital.
Thank you, Ray. Again, like Ray said, I'm Bill Applegate, and this is Claire Kamel. We're two of the lobbyists from the Washington, D.C. office for the American Society of Transplantation. And essentially, as Ray said, we are the eyes and ears and the boots on the ground, but we're far from the most important part of public policy and advocacy, and that's you as family members, patients, donors, recipients, the community that truly is the rubber hitting the road in terms of what transplant is all about. We want to talk today a little bit about how to fight for your right, Advocacy 101, and why that is such an important role and is often left out of public policy in Washington, D.C. Both Claire and myself worked in House and Senate offices on Capitol Hill, and we saw firsthand what works effectively and what falls on deaf ears. Typically in Washington, D.C., everybody smiles and gives you a good meeting, but the trick is really to get them to lift and to get involved on your issue after you've educated them, to attempt to mobilize them into advancing policy that benefits you and the transplant community. So Claire and I are among thousands of lobbyists that are up on Capitol Hill every day of every week, walking the halls. And just because congressional offices know you, they know who you represent, doesn't necessarily mean that they're completely moved. And that's why it is so important to have patients, donors, and family members involved in advocacy activities. Claire, I'm going to turn it over to you for a second just to talk about the environment that we're in right now from a public policy.
Sure. Thank you, Bill. We are, I think everyone can agree, regardless of their politics, that we're in a very unusual time in Washington right now. The good news is there's a lot of partisanship, but the good news is I think people are involved like never before. People like yourselves are willing to get in there and active in their communities and in their government like never before. And so Bill and I have been really happy and love seeing the response about people who are willing to come with us to DC and up to the Hill, who are willing to talk, because we love our jobs and we could go up to the Hill all day long and talk till we're blue in the face, which we do, but it's invaluable to have patient advocates come with us and share their story. You all are truly the constituents of members of Congress and of senators and the administration, so it's so important for you all to come with us. It is elected officials' jobs to represent you. And so we want to make sure we are putting them all to work and making them do their job. And you all have a wonderful story to tell. Don't forget that. And it's been great to watch it progress this way, especially from the transplant community.
Sure. Claire, I also think politics as usual or unusual. I would think Claire would agree with me. We see this every day, and it's not getting better. It's an environment that doesn't operate in the normal course of events. We call it regular order. And regular order has been something that for the past couple of years has sort of gone out the window, which means you really do have to appeal sort of on an uber level to politicians. And as much as the environment has changed, some people think it's the administration, some people think, as Claire said, that it's politics and it's bipartisanship on a level that we really haven't seen in the past. But I think what you're seeing, regardless of that environment, is it is making some people work in a more cohesive way. Coalitions are working stronger than ever in Washington, D.C. because they know they have to in a pretty difficult, challenging environment. Having a voice, having a seat at the table and influence, that's what's key to moving legislation. All of you have 2 U.S. senators and 1 member of the House of Representatives. That's your universe. Anybody else may be sympathetic to your issue. They may want to be helpful, but the tip of the spear, there is no question, is going to be those members of Congress and their congressional staff that identify you as a constituent. And what does a constituent mean? It means that you vote in the district, you pay taxes in the district, you have friends in the district, you have a footprint in their district. Why do they care about that? because all 435 members of the House of Representatives are up every 2 years for re-election. That's not a lot of time. They're constantly fundraising. They're constantly increasing and expanding their outreach in their district if they want to get elected. And then your other members of Congress, you have 2 U.S. senators. There's 100 of them total, and they're up every 6 years. But a third are up every 2 years. Essentially, Congress is constantly running for Congress. And we've seen time in and time out where leaders that you think are undefeatable, they get defeated because they don't spend enough time in the district. They're not close to constituents. They're not identifying key issues where they need to be active. And despite raising tons of money, we saw it just recently, the heir apparent in the Democratic Party. Claire, if you want to mention that.
Absolutely. You've probably seen it on national news. A congressman who was pretty high in Democratic leadership named Joe Crowley. It was found that he wasn't spending a lot of time in his district, and he was defeated by a virtually unknown Alexandra Ortiz. I don't remember the full name. Same thing happened in Indiana a couple of years ago with a senator who was very, very well known, and his legs were kind of taken out from under him when it was found out that he wasn't spending a lot of time in the district. As Bill mentioned, we both worked in congressional offices, and I can tell you right now, even if you're a member of the leadership, Nancy Pelosi or whomever you want to say, when you get mail or you get a phone call into your office, the first question the person on the other end of the phone is going to ask you is your zip code or your area code. And if you're not from their district, it's going to be really hard to get a meeting, or if you get a meeting, to have your voice heard. They want to hear from people who are in their district. So that's why we think that it's so important for the members of the transplant community to come into the offices themselves to tell their story as their constituents. They might not know you, they might not know what you're going through, but they might know your doctor, they'll definitely know your hospital system, and hospital systems are something that are so important to members of Congress, their community centers, their workforces, so many jobs come from hospitals. So it's important that we bring the actual patients from the hospitals into these offices. Members of Congress will want to hear from you, if for no other reason than that.
Absolutely. Thanks, Claire. Using as another example, Senator Roy Blunt, we mention frequently. So Senator Roy Blunt is from Missouri. And a lot of people that live in Missouri, constituents, frequently think that he's just good old Roy. He's a great senator, he's been around, he was in the House of Representatives for a number of years. But what they don't realize, unless they do a little searching or working with lobbyists, is that Roy Blunt chairs one of the most important committees to transplant, and that's the Labor HHS Appropriations Subcommittee. Essentially, Senator Blunt from Missouri, a Republican, is responsible for the annual purse strings of how much money goes into NIH, approves billions of dollars, in fact. If you're from Missouri and you've not spent any time with Roy Blunt, that's a shame. It's a piece that we're missing, and a piece that we're trying to ensure that every member of Congress, of those 535 members, by the way, our universe in terms of healthcare is really only approximately 6 committees. So we're talking more like 50 people instead of 535. And if they know you're a constituent, they know your issues. I think a lot of what we do as an organization, we work with other organizations and coalitions, as I mentioned, the NKF, the ASTS, AAKP. There's about 15 organizations, in fact, national organizations, that are part of a transplant roundtable that meet monthly in Washington to discuss our overlapping issues and to identify issues of mutual concern that we can work on together.
To build on that, though, just because you're a member, you might have a new member, a freshman member, a member you don't necessarily agree with on a lot of things, they're still there to serve you. And just because they may not be on one of these committees of jurisdiction today doesn't mean they're not going to be there tomorrow. So, for instance, we talk a lot about a huge friend of the transplant community, a congresswoman named Jamie Herrera Butler, who was a freshman member, maybe a sophomore member by the time that she was pregnant while in Congress, and through a miracle, basically, she gave birth to a little girl who then needed a kidney. Her husband was her child's kidney donor. I don't know that Jamie Herrera Butler would have been such a champion for transplant. She may have been, but she literally has both a donor and a recipient in her home. So she has just become a champion for transplant. Well, when she started in Congress, she did not sit on the committees that she sits on now, but when she started, she did become a friend of the transplant community. Now she sits on the House Appropriations Committee that oversees HHS, labor, education, which is so important for our community here at Transplant.
That's a good point, Claire. And to take that a step further, we like to say a lot in Washington that you need to make friends before you need friends. You can't run up once a fire is like stage 5 and ask them to get involved on your issue, because it's a process. A lot of what advocacy or lobbying really is nothing more than educating, cultivating, and being able to get a member of Congress and their staff in a position to where they can mobilize when needed. And quite frankly, they can always be mobilized because there's always lots of issues to work on. Another example is someone that you worked with for a number of years, Congressman Bill Pascrell from New Jersey, who was in the wrong party on the wrong committee, but wanted to be active on transplant. And lo and behold, we were friends with him. We brought other groups in to see him, patients. And within about 4 years, he was on the primary committee in Congress, the Ways and Means Committee for CMS. And as you all know, as transplant recipients, donors, family members, we all spend a lot of time working with Medicare, Medicaid at the CMS level. And to have an advocate like that there, where we weren't just getting in line with everybody else once he ascended in leadership, he knew who people were. He knew patients in his district. He knew organizations and issues. Let's see. I'm going to skip over this. This is just more of what we were talking about with 535 members of Congress. It seems daunting, but it's really not. To even have a handful or a cadre of members familiar with your issue. And to tell you a little bit about that, there is a transplant caucus on Capitol Hill. Has more than 50 members that serve on that caucus in both the House and the Senate. And the reason that they care and they're part of this caucus, which is essentially in Congress, it's not an official committee, but it's identified more as like a club, meaning that they have like-minded issues that they care about, and when possible, they can vote and hopefully support issues as a block. And as you mentioned, Claire, Jamie Herrera Butler from Washington State, she chairs that caucus in the House of Representatives. And so we're always looking to have patience with us on Capitol Hill to ask the members of Congress, regardless of legislation that we're working on, we want to make sure that they're a member of the Transplant Caucus. And for that matter, the Diabetes Caucus, the Kidney Caucus, all solid Oregon, and get them as involved and educated as possible. AST, ourselves, and others work to do regular congressional briefings with staff to bring them up to speed on issues. Because again, like anything, not just Congress, it's kind of common sense in business. I can't run into an office and ask you to co-sponsor something if you're completely unfamiliar with who it impacts, how much it costs, how to do it.
Sure, this is just a quick overview on how a bill becomes a law. I think it's underestimated just how hard it is to get a bill made into a law in our country. So I'll just give you a quick overview, and at the end, if you have any questions, you can feel free to ask us about this. So we have 2 chambers of Congress, the House and the Senate, and in both chambers, different members are allowed to introduce bills. Once they introduce bills, they go into subcommittee, and the subcommittee chairman has to be willing to take those bills to subcommittee to be voted on. After subcommittee, then they go to the full committee if they pass subcommittee. The full committee chairman or woman has to be willing to take that to the committee to be voted on. Obviously, you can get political pressures, constituent pressures, but ultimately it is up to the chair people to decide what is being voted on. So it goes, bill is introduced, goes to subcommittee, goes to full committee. If it makes it through all 3 of those processes, then it goes to the House or Senate floor. When it gets on the floor, it's once again, in each committee it's debated. Once it goes onto the floor, it can once again be debated. Sometimes they're not if they're non-controversial bills, and then it's voted on the floor of either the House or the Senate. Once it's voted on, if it is passed through, and not all bills certainly are passed through, it then goes to the opposite chamber and has to be voted on in the exact same way. All the language has to be the same. If the opposite chamber, so if you're in the House, it's the Senate and vice versa, if the opposite chamber doesn't want to vote on it in that way, then it goes to what's called conference, and they work out language between the House and Senate that they can come to an agreement, hopefully, where it is voted. So there are quite a few, well, there are 4 or 5 main bills that we're focusing on right now as AST, and we can talk about those later. But again, Some of these bills we've been working on for 10, 12 years because each Congress, which is 2 years, each Congress has a 2-year term, they have to be reintroduced and you have to start the process all over again.
And to give you an example, a few years ago, as you all know, there's still a donut hole in terms of coverage from Medicare for immunosuppressive drugs. And so we were seeking to address that and make sure that everybody would have immunosuppressive drug coverage for the life of the graft. So there's still that 36-month hole for some patients. We worked with both the House and Senate, had dueling bills, not dueling, companion, I should say, bills introduced in both to work this coverage through. Had some pretty notable people involved on both sides, people that were in key committee assignment positions, people that were in leadership to support both of the bills. We passed immunosuppressive drug coverage so that everyone would have it universally in the House of Representatives. Unfortunately, as it was moving through the Senate, we were a victim of poor timing because the ACA was also moving through the House and Senate. And that may sound like a good thing, except for the fact that they wanted to get a deal done so bad that when we passed the House, there were those in the community that had concerns about how it was going to be paid for. We've heard from dialysis and others that just weren't quite on board with it. And ultimately, it went to what the Senate is known occasionally as the graveyard of legislation. And so we got so close, and certainly it was a victory to get it through the larger body, but getting it through the senior body, getting it through 435 members of Congress to approve it. It's fantastic. We had hundreds of co-sponsors. The Senate, we had the Deputy Majority Leader, who was our key sponsor, Dick Durbin from Illinois, and ultimately we had to start over because they wanted to get the ACA done and they kind of gutted a lot of the bill, and we started over. The next Congress comes up, we reintroduced the bill. A lot of people wanted to see in leadership at the time, the Democrats with the ACA, if in fact that would help and people would get that coverage. We tried to caution them across the board, everybody from NKF to us, ASTS, most of the solid organ organizations, and told them we didn't think that ACA would be able to fill that, and ultimately we found out that it did not. So some good news is about a week ago, Claire and I were meeting with Congressman Michael Burgess, who's one of the good guys in Congress. He chairs the Energy and Commerce Health Subcommittee, which is public health, but he's also an MD. And so being a physician, very, very helpful. He chairs the Physicians Caucus. So I was talking about the Transplant Caucus. There are a number of physicians. There's a Nursing Caucus, an Allied Health Caucus. But he's fantastic. And he summoned us up to the Hill about, again, a week and a half, 2 weeks ago, and said that he wanted to introduce this bill again because he has thought since he got elected to Congress, he's from Dallas-Fort Worth, Texas, that this was just crazy, that this is a broken policy, which all of us already know and agree with, that you'll spend upwards of 6 figures to give someone a transplant and provide them enough gas to basically get around the block a couple times, or 36 months. So we're optimistic that we've got a chairman of a committee that wants to introduce this bill and see what he can do to get it done. Claire, do you want to talk about the woman in the middle is Congresswoman Jamie Herrera Butler that Claire was talking about, and she's been super helpful, but I'll let you talk a little bit about living donor.
Sure, so this is, I mentioned some legislation we're currently working on. This is one we've reintroduced
a couple times,
the Living Donor Protection Act, and this one I know is so important to so many of you who have living donors who have selflessly given you an organ, and currently, right now, there's some issues with pre-existing conditions and yeah, exactly. So we're trying to make it so that when you are a living donor and you've given this wonderful gift of life to somebody else, and not to mention you have to be at pretty peak physical condition, that you are then protected, your drugs are protected, an insurance company can't deny you because you have a pre-existing condition. And the sponsors for this bill, it's another bipartisan bill, are Jerry Nadler from the state of New York and Jamie Herrera Butler from Washington. So we have one Democrat, one Republican.
And I think to echo that, a lot of the legislation that we work on nationally, because when you get a little more granular, maybe people don't always agree on the pathway, but trying to start at 30,000 feet and identify the big issues, whether it's immuno or discrimination against donors. We'd like to think of it and talk to people on Capitol Hill as, it's the American Society of Transplantation and it's the transplant community that generally we're not up there like a number of medical subspecialties asking for higher reimbursement, for those involved in the care of patients. We're up there trying to advance an agenda that removes financial disincentives or policy disincentives to transplant. And there's another piece of legislation that we're working on. Let's see if it's here. The Victor Act. So we didn't even realize that this was a problem to begin with. We actually had somebody from the VA who was a whistleblower who brought the issue to AST and some other organizations and said, did you know that if you're a veteran and let's say you live in Florida and there's a perfectly wonderful medical center, transplant center next door, and you need a heart, there's a strong likelihood that they will say, we don't care, you're going to have to go to Pittsburgh. And again, is that an issue? If they're going to get you to Pittsburgh? Well, it becomes an issue for family. It becomes an issue for travel and subsistence. It becomes an issue for support. And quite frankly, it kind of brings an issue up for efficiencies. And we're always trying to make sense of that. So we brought that to the attention of Congress. A bill was passed in the House, and they're working it out in the Senate at the moment, as well as the funding for it. But essentially what they're doing is this will allow recipients to indeed go to the transplant center next door instead of traveling long distances at great cost. And so this is the Victor Act, which was then rolled into the Mission Act, and VA, DOD, they always come up with the coolest acronyms for their legislation. But this is something that's been great. And again, it's removing a disincentive to transplantation because there were people that were making decisions to not travel because they just couldn't do it. So again, making it as easy as possible. NIH research funding. So this is a tricky one because over the last few years, NIH has become less and less of a partisan issue. There's 12 bills in Congress that fund the annual funding, the annual appropriations for all of the agencies. For us and NIH, it's the Labor HHS/NIH appropriations bill. But it was almost sort of a rob Peter to pay Paul scenario for a long time. You had certain factions in Congress that really wanted money for defense and then Homeland Security, and they would pull it as much of that as they could. Then you would have others that would say, that's great, but you can't do that at the expense of the biomedical research pipeline and continuing to fund the institutes. And you can't just spend a lot of money 1 year at NIH, not do it for 2 years, and then put it back on the front burner. That research doesn't work that way. And through a number of years of a lot of medical associations, societies, patient advocates, quite frankly, the NIH and others, this issue became one that everybody has finally figured out is kind of a big win. It used to be, appropriations-wise, the only big win in town in DC inside the Beltway was transportation because it was bricks and mortar. Those guys and gals never fought against each other, Republican, Democrat, whatever. They knew they were coming back with a new highway or a new road or a new bridge. So how can you hate your fellow congressman or senator when you're in a position that you're on a committee that wins? And what's happened with NIH is that the NIH Appropriations Committee, thankfully, has gotten to that point as well, where it's a big win. It's great. I mentioned Senator Blunt before. It's great that Senator Blunt can come back and say, guess what? BJC, SLU, Mizzou, Wash U, all of these institutions, of which there are numerous, at least 3 or 4 transplant centers. It's a transplant center-rich environment. But in the past, I don't know that Blunt felt that he would get enough credit or love for mentioning that. And so when the Senate just recently adopted a $2 billion increase at NIH, that was the first thing that he spoke about was the institutions, the centers, and the fact that they were going to get more money and that NIH was getting more money. So it's turned a bit of a corner. Now I know that medical research funding is never as much as we would like, and that in real dollars, it's been a struggle. But over the last 4 years in the House and Senate, they've both increased and advanced that dial. And that's something that AST and the transplant community also work in tandem with many organizations, whether it's FASTSEB or Research America or UMR. But it's great to have the transplant example of research out there and in those offices because that actually helps us tell our story on other legislation that's more hard and direct hitting for patients.
Sure.
Engagement?
This is just a couple examples about what AST has been doing with Bill and myself in Washington, D.C. We talked about going up to the members' offices, which I think is something that people came here to talk about, and we can talk more about specifics, about staff, and how to reach out to your members here after this in a little bit. So the coming to DC, again, is invaluable. Meeting with your members if you can't get to DC in their district offices, again, that's why they're there. They want to hear from people, and oftentimes they have a little more time when they are in their district and not running back and forth to votes in DC. Another thing we like to do are congressional briefings. So we try to use different tools. We're talking about doing a documentary viewing to get Transplant and AST in front of Congress, in front of a lot of different staffers, to increase your voice on the Hill and hear what we're working on. What else do we have?
I could just real quick, the pictures that you're looking at, you've got a Democrat or a moderate Democrat who's kind of in a swing district, Ron Kind on the far left, meeting with AST leadership during the, I guess, last year, and or no, the end of the last Congress about 18 months ago. So we try to identify people. He's on the Ways and Means Committee. He's a key member. He's influential, and so we bring in, and what we've done in the past is AST leadership from that state. He's from Wisconsin, La Crosse, Wisconsin. Bring them in to identify. And what's really assisting, and I think growing like gangbusters, is the patient voice and influence in tandem with the physician and other family members to really walk into those offices and say, it's not just about the institutions, it's not just about the physicians, allied health care that are involved. It really is, at ground zero, it's the patient and it's their families. And so that's been very effective, and it's resulted in a lot of individuals working with AST in the transplant community. We've had a half a dozen members of Congress fly out to Phoenix, where we've had our CIOT, our cutting edge and organ transplantation meetings, which usually they don't travel outside the Beltway too often. But we identified with them and said, hey, to Congresswoman Jamie Herrera Butler, we said, we have 5 people from Washington State, and 3 of them are from your district, and they're going to be there, and they'd love to hear from you, to hear what you're doing in terms of patient advocacy. The middle picture, I'm not sure if it's comedy or not, but here it goes. One of our board members, Emily Blumberg, came to meet in our offices, the AST offices in Washington, D.C., with who would have been the domestic policy advisor to Hillary Clinton when everybody thought Hillary Clinton was going to be president. We did a similar meeting with Trump and other candidates at the time, if they had a domestic policy advisor or a healthcare advisor. But we immediately wanted to identify again and hedge our bets and make friends before we needed friends. So, and you can tell by the individual, the male on the right, that just by his body language, he, like a lot of the country, thought that there was no chance that Hillary wasn't going to get elected. And lo and behold, now we're friends with the Trump, healthcare policy advisor. And then on the last picture, Gerald Nadler in the white shirt. He is just a very bullish member of Congress from the state legislature in New York. He's been fantastic. He's been great on our issues. He's introduced the Immunosuppressive Drug Coverage Expansion Act. He's introduced the Living Donor Protection Act. And anytime we've asked him to do anything or intervene on our behalf with federal agencies, he's done that. And I guess that begs the question, too. Claire and I have painted a kind of difficult picture of Congress. So why would you waste your time on Congress if bills are so difficult to pass and if so many things have to go your way? The reality is, much of what we do, lobbying-wise, with federal agencies, we do through congressional offices. If we want somebody to do something at the Department of Labor on FMLA and making sure that patients are covered and they know they're covered, we'll get somebody on the Appropriations Committee in Congress who's responsible for the annual purse strings within that agency to send them a letter, to meet with them, to set up a meeting between us and them, asking them to do these things. So where they may not always react to us, or they may not just react to us and the patient voice, when we involve sort of the stick, the carrot and the stick of Congress, that frequently, gets them over the top, and they realize, hey, this is something that we should be active on. Where do we go from here? Well, why don't Claire and I talk a little bit right now in closing, and we're available for any questions afterwards. But as Claire began with this, the patient voice, that's the most important part. And even if you can't get to Washington, or you can't be part of a Capitol Hill fly-in or participate with an organization, you can certainly use our resources in reaching out to us on our websites. But I would just tell you this, having been a congressional staffer, as well as Claire being a staffer, when somebody calls the office in the local district, meaning in your city or in your county, and you call your local congressional office, and you identify yourself, as Claire said, I'm a patient, I'm a family member, I'm a father, I'm a mother of a child that's either been a donor or a recipient, really would like to come in and talk to you a little bit more about some of the challenges that we're having. And I know you're, a member of Congress and that you work on a lot of, issues and have oversight of things, such as, CMS and HHS for programs that frequently are involved, whether it's Department of Defense, whether it's VA, Medicare, Medicaid. These members of Congress, any program that you're covered by whatsoever, there's a hook back into the federal government because they're the largest healthcare payer out there. So to identify yourself as a constituent that has some concerns, and it's okay to lean on the anecdotal and to talk about your personal issues and how you could be helpful. Almost every congressional office has some sort of informal and some have formal advisory committees on issues. So you can ask and just say, listen, I also wanted to ask you, do you have a list of people that you can turn to when you have questions, whether it's about patient care? We've put a lot of the physicians and folks that work with an AST on a lot of these committees. And again, what are you trying to do? You're trying to be the voice of transplantation. You're trying to be the go-to source for information. And again, we always say, if you don't have a seat at the table, you may well wind up on the menu. And that never was there a more true word spoken than in the U.S. Congress. If you're not in the room or at the table to define an issue and to define some solutions, there will be plenty of people that are already in that room that will define it for you. So with that, I think we've kind of covered the landscape, and thank you so much for coming.
Yeah.
We really appreciate it.
Any questions? Yeah.
A couple of years back at one of the transplant games, there was a visitor from Europe who works on legislation there, and he said privately in a small group, informally, that it was his opinion in Europe that when they tried to improve legislation in favor of making transplantation easier, that there was a real effort by some of the companies that are invested in dialysis and equipment to influence legislators against that. In your experience, are there other entities trying to slow down transplantation for economic reasons? Does that exist in the United States?
Yeah, I think that is the challenge, and it's sort of the intersection of, I'm not telling anybody anything you don't already know, but it's the intersection of business and healthcare, or the business of healthcare and the actual healthcare. And that is probably one of the biggest challenges, if not the biggest challenge that we have on Capitol Hill. I think a lot of organizations see it as a zero-sum game. The shrinking pie of the funding that's out there, and as expenses go up, like for instance with the Medicare pie, organizations, they're not looking to compromise, and so they do largely influence. And to your point with dialysis, even though, as an example, were the immunosuppressive bill to pass, that donut hole, that population, and the cost of, how that would be scored in Congress is so minuscule compared to the overall profits of the therapy of dialysis. And yet, we make the point to Congress all the time that, immunosuppressive drugs, being a quarter of that cost, the dialysis is 4 times as expensive, and that if you're really looking to hit like a cost-effective bullseye, that would be it. But there's no question that we find ourselves sometimes, and that's why we think that we really do need to invoke the patient voice even more. We're up against some pretty well-heeled, well-funded, entrenched stakeholders. So it's a long way of me saying yes.
Mine is sort of a two-part question. One, could you explain a little bit in detail about how Section 504 of American with Disabilities relates to transplant patients? And second off, what, if any, consequences would be on an employer who fails to provide equal protection for an employee?
Sure. And Dr. Lisa Potter talked a little bit about this yesterday in her presentation. So under the ACA, pre-existing conditions, because the ACA is still the law of the land, that should be covered. And again, one of the things we didn't get into the details of, but the Family Medical Leave Act, we were finding that's something that's on the books. And we know when we did some research into the law that that does cover transplant patients. Unfortunately, it got lost on folks. It got lost at the federal government level, and it got lost by private insurers. And so one of the things we were able to do this year was to get some language from Congress in an appropriations report going to the Department of Labor to make sure that they put that on their website, that they communicate those efforts so that patients know that they are covered. But the pre-existing condition, that comes up not infrequently, where employers just choose, or even private insurers will choose to kind of ignore that. And again, that's a challenge that we try to find solutions policy-wise, but that's not always the silver bullet. That a lot of times it's on a case-by-case basis. It's on the folks involved. Yeah. So.
Americans with Disabilities Act, having worked for somebody for 10, 12, 15 years, and you end up with a heart transplant, for example, and then when you try to go back to work, they try to prevent you and try to block you and cut your, not give you the proper promotions and so forth.
That's an issue that I know not just AST, but every organization has identified as trying to come together and find some solutions to, again, ensure that that isn't a policy. Well, it's both, right? It's a policy and a financial disincentive. And they view it as a financial disincentive, too, by denying it, and then, of course, the coming back to work and all of that. And that's part of actually the Living Donor Protection Act is, from a discrimination standpoint, it would ban employers from discriminating. It would ban insurers from discriminating. And again, I think we just have to keep over and over trying to make sure that that all these years of people practicing that way, that's not the way they can practice any longer. So it's a challenge. It's a huge challenge, yeah.
I know that one.
Yeah.
Very personally.
I know. And not to sound like a broken record, but to your point, that's why having your voice and the voice of others to share that particular story. I've been lobbying for about 28 years, and I think they get sick of hearing the same voices and the same, even if it is our physicians and our clinicians and researchers in those offices, very compelling cases they make. But for a Gerald Nadler from New York or Jamie Herrera Butler from Washington State, to have you sitting in front of them as a constituent and sharing that story with them, it's a lot more compelling than listening to two yammering lobbyists and a few organizations. So, and again, go ahead.
No, I also think it's a good example of, Bill uses this term a lot, no pun intended, with the medical community, but lobbying's about, and advocacy is about a steady drip. So you want to continue your advocacy work and your lobbying work even when you don't think it's necessarily needed. So ACA passed, and not denying people with pre-existing conditions passed, but that's not a silver bullet. So you need to remain in focus for these members so that when you don't know when you need a lobbyist until you need a lobbyist, or that you need to be in their office until you need to be in their office. So before something huge like this comes up, or it continues to come up now, because we're not sure what's going to happen with ACA, you're already there and you're at the table and you're in front of them before you have to kind of rewind.
And not to take this in a negative direction, but for years there's been lots of stakeholders, whether you'd mentioned the dialysis community, but there's no question that the insurance community has been there from day one. And they go to great lengths and maybe don't even identify themselves always publicly as opposed to certain things. But the undercurrent, the money, the influence, the voice is there. And as powerful as a patient voice is, if it's not organized and strategic, like they have been for years, you're really up against a formidable foe. And that's why I think you are seeing more patients on Capitol Hill. You are seeing members of Congress. I'll tell you this, as a lobbyist, it's not just about, for me, educating and cultivating relationships. I also will raise money on both sides of the aisle, right? We see things right down the middle. There's nothing partisan about lobbying. We always tell people, you're not in the business of politics per se, in the purest sense, Republican, Democrat, okay? We as lobbyists, if you're going to be good at this, you've got to work with everybody of those 535 plus the administration, regardless of who's in office, that will work with you, right? Otherwise, you're only going to be in vogue, every time there's your party, there. But to be organized about that and to have folks involved, the fundraising, the reason I mentioned that, a lot of people think you have to pay to play. And if you're not a big corporate blue chip company that's raising lots of money and getting friends to introduce legislation and do your bidding and work with HHS on your behalf, that you're not going to get anywhere. But what we're seeing time and time again is it's the value of getting reelected. The members of Congress don't want that money, the political contributions, so that they can go buy a new watch or a new suit. Probably some did back in the day, or every once in a while some do. But most don't. Most are using that for their political campaigns because they're running every 2 years, every 6 in the Senate. But what is just as powerful, and we know this because we see it all the time, is a compelling story, an above-the-fold story about the work of the member of Congress with patients on key issues, a solution that they've come up with, which is usually a solution that we've brought to them and made them aware of, and a reason for them doing it. So, talking about American Disabilities Act, the average member of Congress, if you brought that to them, or if I brought that to them and said, we got to fix this, they would say, you know what, you're right, it's a problem, but I'm also working on all these other things. But if I come to them and I say, I have constituents, patients in your district, in your state, really would love to get this done. There's a number of ways that we could do this. Plus, think of the press potential from this. The fact that you can announce that you are removing a major financial disincentive to what we all know is right, and that's patient care. And so that story is as powerful as raising $50,000 for somebody that you're just giving it to their campaign because you share their spirit for public policy. And that's why I think trying to capture this voice and making sure we're in the right offices. I know AST, we're all in terms of trying to provide the resources to enhance and make that voice louder by working with the patient community, as is evidence of, this is actually our first year here at the Transplant Games, and I know we're planning to be there again next year. And there's obviously a lot of patient organizations. We've got American Association of Kidney Patients, for instance, which is patient board, patient CEO, patient driven, and so just collectively making it more of a strategic voice.
Thank you.
Thank you.